I'm here with Greg Richer, another resident, second year, and then our guest today is actually Armin Valdes. So he is one of our residents, just starting, but he's actually a pediatrician, which I think a lot of you guys already know. So Armin, how's it going?
Pretty good, pretty good. Happy to be here joining the EM program. And yeah, right now, just prepping for my boards, which are going to be in October, and excited. Thanks for inviting me.
That's awesome. And then so today we're going to talk about, since he's a pediatrician, Armin offered to chat with us about a topic of that really a lot of us, if we don't have children, I think, and just haven't spent a lot of time with kids, may have a difficult time with initially. And that is basically like what is normal amongst little people. So why was this talk important to you, Armin?
So Ryan, we're going to start off our PEDS month, right? So it's important to know what normal is for when you see abnormal in the emergency department, it pops out right away. Take, for example, whenever you're going to go out on a hike, it is normal for you to have hiking boots on. Abnormal would be what a couple of the interns and I saw on our AWLS search and rescue. This guy was hiking, but he didn't have those hiking boots. And if I get closer, he had flip-flops on. And that is abnormal. You guys from California, we got to give him a chance.
Well done.
Who is that guy?
Who is
what
that
was he
guy?
thinking?
I don't know. But he walked the whole way in flip-flops and he was tough about it. I love that. Well done, Armin. All right. So what I was thinking to talk about normal is I'm going to present a little case here, or, and then maybe we can discuss this case, Armin and Greg. So let's pretend we are in like a community hospital. We are the emergency providers. It's 3 a.m., and a mom checks in with her 4-month-old baby. The 4-month-old, he's breastfed. He was born healthy. But the mom reports that every time he eats, he has like an effortless regurgitation of the food. So she's a little worried about that. She says he's vomiting a lot. She's also worried that she says over the last few weeks, she's noticed sometimes he'll go 3 or 4 days without having a stool. And so she's a little bit worried about that as well. So there's no pain, there's no fussiness. And then there's no change with the maternal diet. She's been keeping her diet normal. When you look at the baby looks well. The exam is unremarkable. His vital signs look good, 118, respiratory rate of 26. His temperature is 37. On initial evaluation, you don't see anything concerning. So what do you think, Armin? How are we going to approach this?
So the approach that you want to take is just whenever the patient comes in, he's getting his vitals checked in the triage, and you're going to pull up his chart, right? You want to check his vital signs, and as we all know, the vital signs in PEDS are all over the place. Ballpark, you want to know that in newborn or neonates from 0 to 28 days, his respiratory rate is going to be at around 50, okay? And there's an inverse relationship with age, right? As the infant gets older, the respiratory rate is going to decrease, okay? At adolescent age, he's going to reach the adult range. So you want to take that into consideration, but with the clinical context of the patient when you see him. Now, if he's having this respiratory rate at around 50, but he has the nasal flaring, he has intercostal retractions, maybe he has some abdominal breathing or suprasternal retractions, which is a very bad sign. It means that he's just pulling, trying to pull for his life, pull air for his life, then that is worrisome. But always, again, we don't treat numbers, we treat the patient and just take that into consideration whenever you see some vital signs or the respiratory rate at that range. And also the heart rate. Heart rate, neonate, it's going to be from 80 to 180. Above that, then you start thinking of secondary causes of tachycardia and the clinical context again. And if once the patient starts growing into an adolescent age, the heart rate range is going to be reaching the adult range as well. And for blood pressure, it starts off on the softer side. A neonate's going to be around 60 over 30, and it's going to start increasing until, again, you reach the adolescent age, and it's going to be around 115 over 75. Now, there is a formula that you could have in the top of your mind just to know if the patient has hypotension or if the range is normal. So for median systolic blood pressure, you're going to want 90 plus 2 times the age in years. Okay. So if you have a patient that's 6 years old, 6 times 2 is 12 plus 90. So the mean systolic blood pressure is going to be about 112, 102 rather. And that would be the mean systolic blood pressure that you want to get. And so for hypotension, you want to do 70 plus 2 times the age. Okay, anything below that, then it's hypotension.
Yeah, and so those are good points I think you make, that like respiratory rate with young people, they're so variable. I mean, you said 30 to 50 for neonates, 20 to 40 for infants. It's such a big range that, like you were saying, looking at the accessory muscle use is probably more of an indicator than the rate itself. Um, yeah, and then the blood pressure thing though, that's pretty tricky, like doing all those math, in your brain. How do you actually do it in real life?
So yes, it's very tricky, and I don't do the math in my in real life. That's why I chose medicine and not another career, because I hate math. But there's something that helps me out a lot. It's the pediatric BP calculator. I'm not associated with them, but I use it a lot. So it's only 99 cents, and it helps you out a lot. So what you do is kind of plug in the sex of the patient, the age, the height, and the blood pressure that you got in triage. And with that, then you're going to look at the percentiles. Like in peds, we see everything in percentiles, right? 90 to 95th, that's kind of like the high blood pressure, pre-hypertension, right? From 95th percentile plus 12 millimeters of mercury, that's stage 1. And then above that, that's going to be stage 2. And usually you're not really going to treat the first 2. And if you have a stage 2 hypertension, then you're going to want to rule out secondary causes of that, which we're not going to speak of that at the moment.
Yeah, sure. And then, okay, yeah, I mean, so from the triage note, you're looking at all these vital signs. You're going to throw in this pediatric calculator to make sure the blood pressure is okay if it looks abnormal. I definitely know when we work in the peds area, though, the growth charts have percentiles as well. Do you look at the growth charts or do anything with those as well?
Yes, that's a very good question, because again, before you see the patient, you want to pull up the growth chart, especially if they're coming in, they've been sick for a while, and they're a known patient. You want to pull up the growth chart and hit the drop down menu button. Then you go to right there in growth chart, and you're going to pull up something like this. Okay, what you want to see if the patient is following their own curve. That would be normal. Okay, you see the weight, which is in the bottom, and he should be following his own curve. But if you see right here, at around 12 months of age, he is starting to cut percentiles. Okay, if you cut more than 2 lines of percentiles, then you start thinking of something called failure to thrive, which means the patient's not getting an adequate amount of calories, and he's not growing well, he's not gaining weight. And so whenever you have this, and again, the clinical context, maybe you have a patient that has recurrent sinopulmonary symptoms, cough, shortness of breath, some copious mucoid secretions, diarrhea maybe, and you have this type of growth chart, then you're going to want to start thinking of maybe cystic fibrosis or any other type of disease that's going to give you this pattern of failure to thrive. If also besides crossing the 2 percentiles, you want to see if it's less than the 5th percentile, then also that's kind of diagnosis of failure to thrive.
Mm-hmm.
And taking into consideration weight, whenever you have a newborn, the patients are allowed to lose 10% of their weight. Okay, so if you have a patient that's about 3.5 kilos, in the first 10 days, he could lose those 350 grams, which is the 10%, right? At 10 days, 2 weeks or so, you're going to want to see that patient reach his weight and then start growing or gaining weight 20 grams to 30 grams per day.
That's actually a really important point if you look at growth charts, because you could see a baby was born 5 days ago. It looks like he's losing weight. Mom's like he's spitting up. You could be a little worried that this is failure, but knowing that they can lose 10% of their body weight within the first week, that's probably pretty important information.
Definitely.
Here's a quick question for you, Armin. Is it possible to interpret a single value on a growth chart, or you have to see a trend?
That's a very good question. You see at least 2 points so you could see that trend. Yes. So 1 point wouldn't give you much information because you don't know his baseline.
Yeah, just thinking about the kid that you haven't met before. That's a sweet feature in Cerner, though. I'm glad you showed me that. I didn't know that was there.
Mm-hmm.
Yeah.
Also, whenever you see the vital signs, really quick, you're going to go into the room and the patient's going to be freaking out, okay? Because he doesn't know you, or if he knows the doctor, he knows that you're the one that he sees, and then he gets the shot, so he's already having all that PTSD going crazy in the room. So you want to be, look at the patient and kind of interact with him, try to grab his attention. What I do pre-COVID areas, I would grab a glove and then fill it up with air, kind of twist it, make it into a balloon, and start playing with it while I'm interviewing the mother, okay? And at that time, I'm going to kind of grab the patient's attention, and I'm still not looking at him that much, but he's looking at me, he's looking at the balloon, he wants to play with me now, right? And after I'm done interviewing the mother, then I'm gonna grab the glove and give it to him. And once I give it to him, he's gonna be happy because he has the glove, and I could listen to the chest, listen to the lungs, heart sounds and all that. So that's very important. And whenever you're looking at the patient, something that I like a lot, that PALS reviews it a lot, is the tickles mnemonic. So whenever you have that, T is for the tone, right? You want to see the patient that's moving his arms well. That means his muscles are getting good oxygen. That means he's well appearing, right? And also if he's interactive, whenever you have that balloon, that glove, if he's kind of wanting to grab it, he's kind of smiling now, then he's interactive, right? That's good. C is for the consolability, and this is going to be very important because he's never going to be consolable if he's in the bed. If he's in mom's arms, that's when he's consolable. So don't think that you have to explore the patient in the bed. You could explore the patient in mom's arms, and if he's consolable, then that is a good sign as well. The look or the gaze, that's L in the mnemonic. That's very important as well because sometimes they're just lost, So if they're lost, if they're just have like an empty sight or vision, then you're going to think something is wrong and you act quick. And the S is for speech. Most of our patients are not going to speak, but the cry, it's very important. If he's crying loud, odds are that he is pulling good air and he's not as sick as you think, okay? If he has a weak or faint cry, then you start going down the toxic route or kind of looking at some pathology.
I like that you use the word explore instead of exam the kiddo. Yeah. That's awesome. All right, so for this kid, for an example such as this, 4-month-old, spitting up, not really stooling as much, you look at his vital signs, you look at his growth chart, you go in there, you just get a look at the baby, do kind of the tickles thing. And then usually I think like the next step would be to kind of like start evaluating the ins and outs, because that seems to be the concern of the mom. What for like ins, let's start with ins, like what do we expect normal to be for this kiddo?
So normal for that, for patient in the newborn period or breastfeeding, formula feeding, you're gonna want 8 to 12 feeds per day. That is a lot. You're getting about feed Q2, Q3 hours. Okay, formula feeds, since it's a little heavier, then it's going to decrease the amount of feeds, but you're still getting about 8 feeds per day, which takes us to the second point. This patient is going to have, the AP says that for bowel movements, you could have a bowel movement after each feed. So if he's feeding 12 times a day, don't get freaked out if he's having 12 bowel movements per day. Okay, now we go to the end, the other side of the spectrum, and the patient could have a bowel movement every week in the newborn period. Okay? And you're like, what? Every week? That's constipation. No, that isn't. If you do not have abdominal distension, if the patient's eating well, if he's not fussy, if he is passing bowel, if he's doesn't have any history of the kind of passing painful or hard stools, then that is totally normal, and you reassure.
Mm-hmm. So to go back to the ends, so that's a lot. You were saying every 2-3 hours. That's a lot of food. That's a lot of eating. And I assume as they get older, they eat less and less and less. Correct? Will you ask the mom? Because I mean, if we know that's the range of the newborn, 3 months down the line, is there like a general, this is how much they should eat then? Or do you just ask the parents, like, is he eating more or less than usual?
So you want to ask kind of what his baseline is, and then to ask, like you mentioned, if he's eating more than usual, less than usual. But you want to check the output, and the output also would be the urine output. And how do you ask that? You ask it as in wet diapers, okay? You want to ask if the patient has had, how many wet diapers has he had in the last 24 hours? Now, it's very important to ask in the last 24 hours. And I'm very specific with the patient, so I'll say, right now it's 3 p.m. Since yesterday at 3 p.m., how many wet diapers have you changed? Okay, so if it's more than 5, that means he's getting adequate hydration, adequate intake, and so you're fine with that matter. Okay.
Mm-hmm. And then do stools, like you were saying, it can go from every time they eat to a week out, basically, for the newborns, the younger ones. I'd assume it becomes more consistent as they age, correct?
Yes, that is correct. Yeah, it gets more consistent, more like normal adult patterns. Okay. What I tell the patients is that, parents, is that everybody has different bowel patterns. And I tell them, okay, I'm not going to ask you, and I'm not going to tell you either, but you and I have different bowel movements, different bowel patterns. Okay. Maybe you have a bowel movement every 2 days, and that's okay with you. Maybe I have a bowel movement after each feed. Okay. That doesn't mean I'm constipated or that you're constipated or that we're sick. It's just our bowel habits. So as long as, like I mentioned, he doesn't have any emesis, abdominal distension, he's not fussy or not wanting to eat anymore, then he's okay.
Mm-hmm.
Cool. So that's really helpful. I never thought of it that way. The variability. So would you say it's not constipation unless there's decreased bowel movements plus a hard sign, distension, irritability, hard stools?
Yes, and that's in the newborn. Now, once you start getting older, you have something called the Rome criteria, which you have to have more than 2 of the following. If the patient has less than 2 bowel movements per week, okay, that's 1. More than 1 episode of fecal incontinence, that's what we call encopresis, right? You have that hard stool in the intestine, and then you're eating, you have the milk ingestion, right? And that liquid is going to squeeze through that hard stool, and then once it squeezes, it's going to squirt out. So parents could say, you know what, he's having diarrhea. You're like, okay, so has he had a history of constipation? And they'll say yes. So you're like, okay, that is not diarrhea. That's encopresis. Why? Because it's squeezing through. Another one of those criteria is just large fecal mass in the rectum. Another one is dyschezia, which means just a painful bowel movement. He's crying right after he passes a bowel movement. And with that, another one of the criteria is if he has history of retentive posturing, or what we call stool withholding behavior. Why does he have this? Is because he remembers that time that he had that dyschezia. It was so painful that he doesn't want to have a bowel movement again. So he has that stool withholding behavior. Maybe mom's going to say, yeah, whenever he wants to have a bowel movement, he'll just go into the corner and just kind of curl up. So that is a sign of stool withholding behavior, which means that more than likely he meets one of those Rome criteria. And last one, he has a history of large diameter stool that, get this, they could even clot a toilet up. I've seen little penguins large adult size stool. So yeah, always ask that, and you'll be surprised what you find.
So that's interesting. I mean, so that Rome criteria, it's pretty interesting, but I mean, like Greg was saying, basically, if they're not stooling, it's not an issue. But if they're not stooling and there's one of these symptoms to go along with it, which, apparently it's a criteria, that's when you call it, constipation. If, okay, so let's say that we have this kiddo, for example, this kiddo doesn't seem like he's constipated, but if we did have a kiddo that we think is constipated, what's your kind of go-to treatment?
So go-to treatment is Miralax. And Miralax, you're usually going to do a 3-step approach. You don't want to fall into the routine that we all fall into, just giving that 0.8 grams per kilo or 1 scoop, that's 17 grams per day. That is not the way you want to start off with. Why? Because whenever you give Miralax, you do a 3-step approach. First step is the disimpact phase. Second step is the maintenance phase. And the third step is the rescue phase. So for the disimpact phase, you want to tell the mom you're going to give, if they're less than 15 kilos, you're going to put 4 scoops of that Miralax into a 32-ounce fluid of your choice, and they're going to chug it, okay? Because you want to disimpact. Remember that hard stool that's there? It's not going to go away with the maintenance phase, okay? You want to disimpact, and you want to do it good. And you could repeat that. Now, if they're greater than 30 kilos, then you could put 7 scoops in a 64-ounce fluid of your choice, and you could repeat that as well if you don't have that bowel movement. Now, after that, you're going to go into that maintenance phase, which is what we all know, the 0.8 gram per kilo, or you could do the cap per day, just so you can have soft, mushy stools. And you want to tell the mom that, okay? And they could titrate it, because it's really not, it won't hurt them if the patient's mom titrate them. And at the third phase would be the rescue phase. Whenever you're not having a bowel movement for more than 48 hours and he has the symptoms that we've been talking about, then you could stimulate the bowel with Dulcolax.
Dulcolax suppository?
Correct, yes.
Yeah. That's pretty good. That's pretty good discussions. I think a lot of times you see just the single scoop for a lot of kiddos, and just to remember, you need to get that stool burden out, that initial one. So 4 scoops seems like a lot for a baby. So that's pretty good to know. 7 cap seems like a ton, but that's for a big kid. That's probably 70 or 80-pound kid. So that's definitely older than we've been talking about. Can you use these like for all ages, or is there kind of like an age range we should be using this regimen for?
Okay, so the cutoff that I would do is 6 months, maybe a year. Okay, you don't want to start them off right away. You want to look for another pathologic cause that's causing this constipation. But what you could do in these patients is do prune juice, where maybe 4 to 6 ounces per day, and that usually gets the bowel movements rolling, and they don't have a pathological cause that's causing this constipation, then they'll do well with it, and they could just wean it off.
Mm-hmm. Prune juice is great. It's just hard to get kids to drink.
Correct. Yes. I won't even drink the 4 to 6 ounces. It's very easy to prescribe it, right? But also talking about bowel movements and secondary causes, you want to ask if you have a very young patient, 6 months or a year or less, you want to ask if she or he passed a bowel movement or meconium in the first 48 hours. Why is that? Because you want to rule out that Hirschsprung disease.
Right. But if they have normal prenatal care and a normal delivery, in the U.S., won't they usually have them stool before they leave the hospital initially?
Yes, that is correct. Yeah, you have to pee and you have to poop before you get discharged.
Okay, so hopefully we don't see that, but if we do, we always consider Hirschsprung's. It's a good thought. So we've talked about the urine, how much they should be peeing. We've talked about how much they should be eating. We was talking about poop quite a bit. So we've talked about the frequency. How about the consistency of poop? Because kids have funny poops.
Yes, they do. So again, in the newborn, you will have the color. First of all, it's going to be kind of, at the beginning, it's going to look like, I hate to use food, but we have to. So kind of like an avocado type of color. It's going to be soft, smushy. If they're breastfed patients, then they're going to have seeds. I've had patients come in because mom is worried, maybe she's a G1, P1, or first time she feeds, that the patient has little seeds in the stool, which is totally normal, and all you need to do is reassurance for those patients. And so once that meconium is passed, you go from that avocado color towards the peanut butter type of color, and it looks as smushy as peanut butter.
Yeah.
A breastfeeding kid can have seed-like appearance to the stool, and that's okay.
Yes, that is correct.
All right, that's really good to be warned about, not being a parent.
Yes, yeah, exactly.
Yeah, I remember with little ones, my wife crossed over. There's endless streams of just this yellow, grainy, sandy stool. I mean, you're just changing it all day, I feel like, since this yellow stuff. And then what about though, for a lot of kids, probably around, I don't know, 4 to 6 months, they're gonna start trying some fruits and some human food, right? What happens then?
So first of all, parents are going to be depressed. Why? Because breastfed patients that are purely breastfed, stools don't really smell bad. Okay, so they're going to miss the old days. But once you start getting that diet in 4 6 months, you start introducing solids. Then the bowel movements are going to start decreasing a little bit, and also they're going to increase in consistency.
Hmm. Hmm. They turn into adult poops.
Basically,
Yeah. And then I've heard of sometimes kids can get like little specks of blood in their diapers. What should we do with that?
that's really good you mentioned it. So 2-month-old infant comes in, vital signs are stable, he looks great, but mom brings the cell phone and she shows you a picture of uh, poop with specks of blood. But again, patient looks non-toxic, vital signs are stable. You see those two points in the growth chart and it looks great. This could be so protein-induced enterocolitis, and this is in purely breastfed patients, okay? Or you could see it in formula as well, and they get a cross-reactivity or kind of like an allergic reaction in the intestine, and that causes you to have the specks of blood in the stool. This could be, and how do you treat it? You just tell mom to not take any dairy products or soy products because of, again, that cross-reactivity. And you should see an improvement or no specks of blood at around 72 hours when the diet changed.
It's a super important point. I can imagine being at like a small hospital and some mom comes in, it's like, there's blood in the stool, and you like freaking out. Yeah, putting them on an ambulance, shipping them out to the next pediatric center for something so simple. So it's really something good to know about. So that's good. So we've talked about eating, we've talked about peeing and pooping. So maybe we kind of, circle back to our vignette that we started with. We had this 4-month-old baby, breastfed, otherwise healthy. He's been spitting up like effortless regurgitation after a lot of liquid meals. What do you think about that?
Okay, so this patient has reflux. Reflux, it's gastroesophageal reflux, right? We're used to saying GERD, and GERD is whenever you have reflux, but he's having retching, he has maybe hematemesis, maybe he has failure to thrive. So it's starting to cause a toll in the patient's system. So whenever he's thriving, whenever he's looking good, vital signs are stable again, and he just has these spit ups, then it's just GER without the D. So gastroesophageal reflux. And this could be normal up to a year. Okay, up to a year. So you need to talk to the mom and reassure her well and tell her, you know what, most of the infants have this, and about 95% of these patients are going to improve at 1 year. There's a 5% that's not, but then you would do something else, maybe refer them to GI. But if he's thriving, if he's looking good, non-toxic, then it's just gastroesophageal reflux, and you just give him a nice prescription of reassurance.
Mm-hmm. That's good. I like that you use the word spit up, because spit up, I think, doesn't sound as offensive as when mom says she's vomiting. You could probably just try to really differentiate those two things.
Correct. And yeah, so I'll remember vomiting, you're going to be using your abdominal muscles. You're going to be wrenching. You're going to, now spit up is just kind of trickling down the cheek, right?
Mm-hmm.
So some way that I use for my my moms that come in for reassurance, I tell them, you know what, I don't know if you've ever gone to a buffet, ate so much that you want to go to sleep right afterwards. right? And they're like, yeah, it happens. Yeah. Okay. So whenever you do that, what happens? Your stomach is so full and it can't go down towards your intestines, and it's going to kind of open the door to the esophagus, right? And what happens is that you have that food that's going to come out towards the mouth or just give you that heartburn. Have you ever had heartburn? They say yes. So it's the same thing that the patient is going through at the moment. You feed him, okay? And when you feed him, you lay him down immediately. So he's going to have that reflux and you're going to get scared, but you shouldn't. You just need to do what we call reflux precautions. Reflux precautions is burping the baby well. Sometimes, and I exaggerate because they're not going to hit that mark, but you want to do at least have the patient's head up about 30 minutes after each feed. That way they don't have these reflux situations. And so parents get it, they relate, and they're happy about it.
Sure. And the other thing, I mean, to consider in this is like we were talking about earlier, these moms are feeding every 2 to 3 hours. It's been 2 weeks and they're getting 2 to 3 hours of sleep, in blocks. And so I don't think it's uncommon to try to feed in the middle of the night quickly, rush the burping period, put them down, and that makes them spit up a little more. So really emphasizing, like you have to take the time to burp and pull them up. I think that will reduce it. Have you ever seen those incline pillows? What do you think about those?
Yes, so that's part of the reflux precautions. We really don't use them as much, the wedge pillows, but if he is having severe reflux, you could talk to them and let them know that they could use these wedge pillows. Now, whenever you talk about that, you have to tell them not to have any plush toys, any like quilts or anything like that because of the risk of SIDS. That's why you kind of really don't want to gear him that way. But if you think that he has severe reflux, then you could definitely let them know about the wedge pillow.
So we're getting into some really good pediatric primary care here, but I just want to go back and talk about what are the historical things that you ask to differentiate spitting up and vomiting, just on a basic level. I think I got a couple of them already, but you said it should be effortless. Should be usually probably after a meal, I would suspect. What are the other things that are separating red flag from benign when we're talking about spitting up versus vomiting?
So those two are the main ones, Greg.
Okay.
You want to add, and don't ask them, is it usually right after the meal? No. You want to ask mom. So what do you do right after you feed the baby? Okay?
Okay.
You don't want to gear them for them to answer what you want to hear. You would just want to ask, what do you do right after you feed the baby?
Open-ended.
Well, I lay him down. Okay. So that's why he's having this pain. You just
And anything in the category of like red flag type that's going to make you think maybe the mom describes it in a benign way, but you're thinking, oh, this sounds a little more concerning.
So yes, if the patient's not, mom's not going to tell you as much, but if he's not gaining weight, if the patient's not having good urine output, okay, that means he's not absorbing it into systemic to his system, then those are red flags. Also, if it's kind of projectile, then you want to something else.
Nice, cool, thanks.
Cool. So for this kiddo that came in that we've been talking about, it sounds like he has GER, not GERD, right? Not a big deal. He's not stooling a lot, but he doesn't seem to be uncomfortable. So it's 3 a.m. This mom is frustrated and thinks she's not doing a good job as a parent and worried about her kiddo. And basically everything's totally fine, right? So what is your approach? How do you kind of like reassure mom and tell them basically there's no medicines, there's nothing wrong? How do you approach that?
Yeah, and the reassurance is the main thing you're going to want to do. That's the only treatment that you're going to give the patient, but you have to sit down with them and explain. The example that I gave about after, feeding after the buffet, that's very good. They usually relate with that, but also pull up the chart, print out the chart, because you don't want this patient to come back again unless he has, some other symptoms, right? Because it's could be a waste of her time and your time as well. Why is that? Because you didn't take the time to reassure the patient. So pull up the growth chart and say, okay, so he's growing well. He has good year. He's growing well, which means that his body is digesting the food. Yes, some comes out of the mouth, but he is growing well. He's meeting that caloric needs. He has good urine output, which means more than 5 wet diapers. So if you don't have more than 5 wet diapers in 24 hours, then you want to bring him back. That means that he is not absorbing the food as well. Now, what you mentioned about the vomiting, I don't call that vomiting. I call that spit ups. Why is that? Because you use your abdominal muscles and you just kind of go through what you ask, but reassure them in a way that they feel better. And I always tell moms, it's good that you brought them, because it's 2 o'clock in the morning, it's 3 o'clock in the morning. Obviously they didn't want to come see you or come into the hospital. So it was so important to them that they stopped sleeping and they came to you. So just take the time and explain to them, and they usually get the hint, and they're happy about it.
Yeah, that's really good. I mean, a lot of pediatrics is reassurance, I feel, and then weeding out the dangerous things. So, well, this has been a really good discussion. I think some of the really things that I think are really important to remember that I am going to take out of this is that whole after they're born, they can lose 10% of their weight. That's like something I think super important to remember, so you don't worry about it. I do like the Miralax, the three regimen, the 3 pieces to it. I think that's something I'm definitely like incorporating into my practice for sure. Yeah, I think it's pretty good. How about you, Greg?
Sorry to interrupt. For the feeding, also, if they're formula feeding, you just want to ask how they prepare the formula. Okay, that's very important, because there's patients, and especially in our population, that they want to get more bang for their buck. If you ever bought formula, it's super expensive. So what you want to ask them is how they mix the formula. Usually it's going to be 2 scoops or 2 ounces of water with 1 scoop of formula. Okay. Sometimes they'll dilute the formula, not because they want to hurt the baby, not because of anything else, but just ignorance, or they just don't know it could harm them. So what happens if you put more water into that formula? First of all, they're not going to grow, they're not going to gain weight, and they could come in for hyponatremic seizures, right? Because you're getting that water in, you dilute the sodium, and that's a cause of seizures. Not very common, but always have that in the back of your mind whenever you have a seizing patient or a patient that's not growing well. And it's a very simple question to ask. Just how do you mix the formula? Okay, 2 ounces of water, 1 scoop of formula, and it's good to go. Okay, next question. It's really quick, but you could get a lot of that. A lot of it.
That's good.
Yeah, I agree with you, Ryan. This session's been really useful. I was taking notes as we went. For someone who's not a parent, this stuff is the normal stuff is intimidating, because the parent comes in and they're looking to you for advice, and you say, oh, well, I don't even know if that's normal. So having the tools that Armin said, and then knowing how to kind of pull out a history about constipation, pull out a history about spitting up, I'm going to use those going forward. The only thing left, I don't know if you use PD Stat. I've heard a lot of good things. I haven't really incorporated it. Armin, is that an app that you find useful?
Yes, it's very useful. I recommend it a lot.
Mm-hmm.
You can find everything there. So yes, make sure you download.
I know it costs some money, but I've heard good things.
Well worth it. Well worth it. Definitely.
Okay.
Download it
Before
going into your peds. Yeah.
Nice.
All right, Dr. Valdes, good luck on boards, and we'll see you around. Dr. Witcher, thank you so much.
Good stuff.
Thanks, guys.
Thanks.
See you all around.